சர்க்கரை வியாதின்னு சொல்லுவோம். அது அதிகமாக போயிட்டே இருக்கு. அதிகமாக வந்துகிட்டே இருக்குது. தமிழ்நாட்டில் மட்டும் இல்லை, இந்தியா பூரா. தமிழ்நாட்டில் பார்த்தீங்கன்னா 5 கோடி மக்களுக்கு நீரிழிவு வியாதி இருக்குது. அந்த நீரிழிவு வியாதி கவர்மெண்ட் ஹாஸ்பிட்டலில், ப்ரைவேட் ஹாஸ்பிட்டலில் மேனேஜ் பண்ணிட்டு இருக்காங்க. பட் நீரிழிவு வியாதி அதிகமாகிட்டே இருக்குது. அது லைஃப் ஸ்டைல் டிசார்டர், டைப் 2 டயபெட்டிஸ். இன்றைக்கி டாக்டர் பன்சி சாபு அவர்கள் பேசுனது டைப் 1 டயபெட்டிஸ், குழந்தைங்களில் சர்க்கரை வியாதி வருது, அதை பற்றி பேசினாரு. அவர் ஃபஸ்ட்டு லேட் ப்ரொஃபஸர் எம் விஸ்வநாதன் அவார்டு ரேஷன் டெலிவர் பண்ணார். அவர் பேசுனது டைப் 1 டயபெட்டிஸ். நம்ம நாட்டில் டைப் 2 டயபெட்டிஸ் தான் அதிகமாக இருக்குதுன்னு நம்ம நினச்சிருக்கோம். அவர் சொன்னது பிரகாரம் டைப் 1 டயபெட்டிஸ் கூட ரொம்ப அதிகமாக இருக்குது நம்ம நாட்டில். இது அப்படி தான் சொன்னார். ஸோ டைப் 1 டயபெட்டிஸு அதுக்கு இன்சுலின் போடணும், டயட் கண்ட்ரோல் பண்ணணும், அண்ட் எஜுகேஷன் கொடுக்கணும் குழந்தைங்களுக்கு. அதுதான் அவர் எக்ஸசைஸ் பண்ணது மெயின் பாயிண்ட்டு. ஸோ நீரிழிவு வியாதி அதிகமாகிட்டு இருக்குது. டைப் 2, டைப் 1 டயபெட்டிஸ் போடும், குழந்தைங்களில் போடும். குழந்தைங்களுக்கு இன்சுலின் போடணும். பெரியவங்களுக்கு சர்க்கரை வியாதி வந்து டைப் 2 டயபெட்டிஸாக இருக்கலாம். அது மாத்திரை கட்டுப்படுத்தணும். பட் குழந்தைங்களில் வந்தால் இன்சுலின் போட்டு தான் ஆகணும். அவர் சொன்னது என்னென்னா, வெளிநாட்டில் பிளட் சுகர் பார்க்குறது நிறுத்தியிருக்காங்க. இந்தியாவில் மட்டும்தான், இந்தியா இப்போ கூட ப்ரொடியூஸ் பண்ணாங்க. சிஜிஎம்னு புது டெக்னாலஜி வந்துருக்குது. அது இந்தியாவில் அது இம்போர்ட் பண்ணிகிட்ருக்கு. இட்ஸ் வெரி காஸ்ட்லின்னு சொன்னாங்க. சார்
ஓகே சார், இன்றைக்கி ஃபஸ்ட்டு ப்ரொஃபஸர் விஸ்வநாதன் அவார்டு கொடுத்ததில் ரொம்ப பெருமையாக இருக்கிறோம். இதான் ஃபஸ்ட் டைம் கொடுத்துருக்குறோம். அது முக்கியமாக டாக்டர் பன்சி சாபு அப்படிங்கிற பெரிய டயபெட்டாலஜிஸ்ட் கொடுத்துருக்குறோம். அதை மிஸ்டர் விஜய் விஸ்வநாதன் சார் அவங்க ஆர்கனைஸ் பண்ணி அதை கொடுத்துருக்குறாங்க. இது எதுக்காக அப்படின்னா, அவருடைய டாக்டர் பன்சி சாபுனுடைய கிரேட் ஒர்க்ஸ் அதை அப்ரிஷியேட் பண்ணி இந்த அவார்டு கொடுத்துருக்குறாங்க. தொடர்ந்து இந்த மாதிரி ஒவ்வொரு ஆண்டும் அவார்டு கொடுப்பாங்க அப்படிங்கிறது பெரிய பெரிய அச்சீவர்ஸ் இன் டயபெட்டிக் இது ஃபீல்டில் அவங்க கொடுத்துட்ருப்பாங்க. ஸோ இந்த ஃபஸ்ட்டு டைம் இன்றைக்கி கொடுத்தது, அவருடைய ஸ்பீச் கேட்கும்போது நம்ம சார் சொன்ன மாதிரி டைப் 2 டயபெட்டிஸ் அப்படின்னா அடல்ட் ஆன்செட்டு, வயசானவங்க ஒன்றே வரக்கூடியது, 30 வயசுக்கு மேற்பட்டவங்களுக்கு வர்றது. இப்போ குழந்தைங்களுக்கே வரக்கூடிய டயபெட்டிஸும் அதிகமாக இருக்குது அப்படிங்கிறத சொல்லிட்டு இருந்தார். அவங்களுக்கு நம்ம ஊசி குத்தி பிளட்டை பார்க்குறத நம்ம குறைச்சிக்கிட்டு கண்டினியூஸ் குளுக்கோஸ் மானிட்டரிங்கிற சிஸ்டத்தை கொண்டு வரணும். அதனுடைய காஸ்ட் அதிகமாக இருக்கிறதுனால இப்போ அதனுடைய டெக்னாலஜிஸ் அதெல்லாம் இந்தியாவிலே ப்ரொடியூஸ் பண்ணி அதை கொண்டு வந்தோம்னா நம்ம குழந்தைங்களுக்கு குழந்தைங்க அடலசென்ட் அவங்களுக்கெல்லாம் டயபெட்டிஸ் கொடுக்குறது டயபெட்டிஸ்க்கு இன்சுலின் கொடுக்குறது சிஸ்டம் நமக்கு ரொம்ப ஹெல்ப்ஃபுல்லாக இருக்கும். இப்போ நம்ம ஏற்கனவே கவர்மெண்ட்டில் அடல்ட்ஸுக்கெலாம் இன்சுலின் கொடுத்துட்ருக்குறோம். இப்போ ஈவன் ப்ரைமரி ஹெல்த் சென்டரில் கூட நம்ம இன்சுலின் கொடுக்குற அளவுக்கு நம்ம முன்னேறி இருக்கிறோம். இன்னும் நம்ம சில முன்னேற்றங்கள், டெக்னாலஜி, காஸ்ட்டை குறைச்சதுன்னா இன்னும் குழந்தைங்களுக்கும் அந்த கண்டினியூஸ் குளுக்கோஸ் மானிட்டரிங் டிவைஸும், அதுக்கப்புறம் ஆட்டோமேட்டிக் இன்சுலின் டெலிவரி பம்ப், இது ரெண்டையும் நம்ம கொண்டு வரலாம் அப்படிங்கிறது தான் இன்றைக்கி மெயின் கருத்தாக இருந்தது இந்த ஸ்பீச்சுடைய கருத்து. ஸோ we are really happy that we have heard an important message which was delivered today. Thanks to Viswanathan. இல்லை, பிளட் டெஸ்ட் இல்லாமல் இல்லை, கண்டினியூஸ் குளுக்கோஸ் மானிட்டரிங். அந்த
இன்டர்ஸ்டிஷியல் ஃப்ளூயிடு டெஸ்ட் பண்ணது நான். இன்டர்ஸ்டிஷியல் ஃப்ளூயிடு ரத்தம் டெஸ்ட் பண்ணாமல் இன்டர்ஸ்டிஷியல் ஃப்ளூயிட்லேருந்து
ஃபிக்ஸ் பண்ணி
பார்க்குறது. இந்த ஃபிக்ஸ் பண்ணி ஒரு பேட்ச் மாதிரி ஃபிக்ஸ் பண்ணி இன்டர்ஸ்டிஷியல் ஃப்ளூயிட் ரத்தம் இல்லை, அது ஃபிக்ஸ் பண்ணால் டெலிஃபோனில் மொபைல் ஃபோனில் பார்த்துடலாம் அப்பப்போ ரியல் டைம்.
சார் நீங்கள் சொல்கிறது வந்து இந்த இடத்துல வந்து ஃபிக்ஸ் பண்ணி சிப்பு மாதிரி வச்சுட்டு அதோட மானிட்டரிங் பண்ணுறது தானே நீங்கள் சொல்ல வரீங்க?
ஆமாம் ஆமாம்.
அதுக்கு என்ன பேர்?
சிஜிஎம்,
கண்டினியூஸ் குளுக்கோஸ் மானிட்டரிங்.
இல்லை, அது வந்து எந்த நேரத்தில் வேரியேஷன் ஆகும் அப்படின்றத மானிட்டர் பண்ணுறதுக்கு தானே அது யூஸ் ஆகும்.
ஆமாம்.
அதான்
அவர்
ஒரு சவுண்டாக பேசுங்க தயவு செய்து.
இப்போது டைப் 1 டயபெட்டிஸ் ரொம்ப ஃப்ளக்சுவேஷன் இருக்கும். அது வந்து பார்க்கறதுக்கு சிஜிஎம் இஸ் வெரி யூஸ்ஃபுல். அது ரொம்ப தேவைப்பட்ட ஒரு கருவி. பிளட் சுகர் பார்க்க முடியாது நைட்டில் 1 மணி 2 மணி. இது 99 ரீடிங் ஒரு நாளில் வரும். 14 நாளைக்கு ஒரு பேட்ச் வரும். ஸோ 1400 ரீடிங்ஸ் எடுக்கலாம் ஒரு வாட்டி பேட்ச் போட்டால். ஸோ சிஜிஎம் இஸ் மச் பெட்டர் தென் பிளட் சுகர் மானிட்டரிங். பிளட் எடுத்து பார்க்குறத விட சிஜிஎம் ஒரு பேட்ச் ஓட்டினா அது ரொம்ப ஈஸி பார்க்குறது. இப்போ வந்து 5000 ரூபாய். அது பிகாஸ் இது இம்போர்ட், அவர் சொன்னது பிரகாரம் இம்போர்ட் டியூட்டி எல்லாம் இருக்கிறதுனால விலை அதிகம். அது இந்தியாவிலே ப்ரொடியூஸ் பண்ணால் விலை குறையும், எல்லாருக்கும் கொடுக்கலாம்னு அவர் சொன்னார்.
எல்லாமே வந்து இட் இஸ் ரிசோர்ஸ் தான். ரிசோர்ஸ் வந்து அதிகமாக இருக்கிற பட்சத்தில் இந்த சொல்லக்கூடியது இந்தியன் ப்ரொடக்ஷன் இன்க்ரீஸ் ஆகி கம்மியாக வந்ததுன்னா we can take the system into the government system. தமிழில் சொல்லணும்னா டெஃபினட்டாக ஆல்ரெடி சிஎஸ்ஆரில் நம்ம நிறைய ப்ரோக்ராம் பண்ணிகிட்ருக்குறோம். இதுவும் வந்து யாராவது முன் வந்தாங்கன்னா நம்ம வந்து தாராளமாக பண்ணலாம். we will try to get CSR support. ஆல்ரெடி வந்து நம்ம ஒரு அந்த டயபெட்டிஸ் டைப் 1 டயபெட்டிஸ் அவங்களுடைய ஃபோரம் ஒன்று இருக்குது. அவங்க கூட இணைஞ்சு நம்ம வந்து இந்த இன்சுலின்லாம் கொடுக்கறதுக்கு குழந்தைங்களுக்கு டைப் 1 டயபெட்டிஸ் இருக்கிறவங்களுக்கு ஒரு ப்ரோக்ராம் பண்ணி அதை மானிட்டர் பண்ணிகிட்ருக்குறோம். அதே வந்து சிஎஸ்ஆருடைய சப்போர்ட் கிடச்சிதுன்னா கண்டிப்பாக நம்ம இப்போதைக்கு உடனே இம்மிடியட்டாக பண்ணலாம். ஃப்யூச்சரில் வந்து இந்த காஸ்ட் சார் சொன்ன மாதிரி டெக்னாலஜி இம்ப்ரூவ் ஆகி இம்ப்ரூவ் ஆகி காஸ்ட் கம்மியாச்சுன்னா கவர்மெண்ட் சிஸ்டத்தில் ரொட்டீனாகவே கொண்டு வந்துடலாம். திஸ் இஸ் டயபெட்டிஸ். சார்
தமிழ்நாடு கவர்மெண்ட் மெடிக்கல் ஃபீல்டில் நிறைய அட்வான்ஸாக போயிட்டு இருக்காங்க. ஸோ இதை நீங்கள் இந்தியாவில் தமிழ்நாட்டில் ப்ரொடியூஸ் பண்ணுறதுக்கு ஏதாவது முன்னெடுத்துறீங்களா?
இந்த மெசேஜ் இன்னைக்கு கேட்கப்பட்ட மெசேஜஸ் நீங்கள் எப்படி கேட்டிங்களோ அது எனக்கு சில இது புதுசாக இருக்குது. அதை நம்ம எடுத்துகிட்டு போய் எங்களுடைய பாலிசி மீட்டிங்ஸில் நம்ம சொல்ல தான் போகிறோம். ஏஐடி ஆட்டோமேட்டிக் இன்சுலின் டெலிவரி. அதை வந்து இந்த ஏஐடி சிஸ்டமை நம்ம வந்து உடம்புல இதே மாதிரி சிப்பு மாதிரி அது ஒரு எக்யூப்மெண்ட்டு அதை உள்ளே அட்டாச் பண்ணிட்டோம்னா அதுவே வந்து இன்சுலின் நம்ம குளுக்கோஸ் லெவல் எவ்வளோ இருக்குது அப்படிங்கிறத பார்த்து இன்சுலின் தேவையான அளவுக்கு அது பம்ப் பண்ணிகிட்டு இருக்கும். ஸோ இட் வில் ஹாவ் அ மோர் எஃபெக்டிவ். நம்ம அப்போ இன்சுலின் காலையில் 10 யூனிட்டு 20 யூனிட்டா 16 யூனிட்டா அப்படின்னு நம்ம வந்து டாக்டர் சொல்லும்போது நம்ம போட்டுட்ருக்குறோம். இது வந்து அதுவே மெஷர் பண்ணி அதுவே வந்து தேவையான அளவுக்கு இன்சுலினை கொடுத்து நமக்கு எவ்வளோ சாப்பிடணும் என்ன இது அப்படிங்கிறத அது சொல்லும். பம்ப்
அவர் சொன்னது புது பம்பு வந்துருக்குது. அது இந்தியாவில் நிறைய பேர் யூஸ் பண்ணியிருக்காங்க ஆல்ரெடி. அது வந்து சிஜிஎம் இணைந்து ஒரு பம்பு. ஸோ சிஜிஎம் அந்த பம்புக்கிட்ட சொல்லும் இவ்வளோ சுகர் இருக்குதுன்னு. பம்பு டிசைட் பண்ணி அது இன்சுலின் டெலிவர் பண்ணும். இட் இஸ் கால்ட் ஏஐடி, ஆட்டோமேட்டிக் இன்சுலின் டெலிவரி சிஸ்டம். ஆமாம், ரெண்டும் சேர்ந்து வந்திருக்குது இப்போ. அது
இப்போ நிறைய கண்டுபிடிச்சிட்ருக்கோம். ஸ்க்ரீனிங் அதிகமாகிறதுனால ஆட்டோமேட்டிக்காக ஹைட் ஆகிட்டு இருந்த டிசீசஸ்லாம் நம்ம நிறைய கண்டுபிடிக்கிறோம். கண்டுபிடிச்சு அதுக்கு ட்ரீட்மெண்ட் கொடுத்துட்ருக்கோம். ஸ்டெப் சர்வேயில் வந்து நமக்கு வந்து 17% 20%ன்னு டயபெட்டிஸ் இருக்குது அப்படின்றாங்க பாப்புலேஷனில். அதை நோக்கி தான் நம்ம போயிட்டுருக்கோம். எவ்வளோ பேருக்கு அதிகமாக கண்டுபிடிக்கிறோமோ அவ்வளோக்கு அவ்வளோ அவங்கள வந்து ட்ரீட்மெண்ட் இனிஷியேட் பண்ணி ட்ரீட்மெண்ட் கண்ட்ரோலை கொண்டு வரணும், காம்ப்ளிகேஷன்ஸை ப்ரிவென்ட் பண்ணணும். இல்லை, உங்களுக்கு தெரியும், இந்த அதுக்கான ஃபோரம் கிடையாது இது. இருந்தாலும் சொல்கிறேன், மக்களை தேடி மருத்துவம் மாண்பு அமைச்சர் அவர்கள், மாண்பு முதலமைச்சர் அவர்கள் இந்த மக்களை தேடி மருத்துவங்கிற ப்ரோக்ராமை இனிஷியேட் பண்ணுறதே இதுக்காகத்தான். வீடு தேடி மருந்து, டயபெட்டிக் மருந்தை கொண்டு போய் கொடுக்குறோம். இப்போ எக்ஸ்பர்ட்ஸ்லாம் சொன்ன அந்த மருந்துகள் எப்படி கொடுக்கணும், அவங்க ப்ரோட்டோக்கால் எல்லாம் டெவலப் பண்ணி நம்ம கொடுத்துருக்குறாங்க. கவர்மெண்ட்டில் சிஸ்டமும் ப்ரைவேட்டில் இருக்கக்கூடிய டயபெட்டாலஜிஸ்ட் வந்து கொடுத்துருக்காங்க. அந்த ப்ரோட்டோக்காலை நம்ம இன்கார்பரேட் பண்ணி வீடு தேடி மருத்துவம் கொடுத்துட்ருக்குறோம். அந்த அளவுக்கு இம்ப்ரூவ் ஆகிருக்கு. அது மாதிரி இன்சுலின் சொன்னேன் இல்லையா, இன்சுலினும் கொடுக்க ஆரம்பிச்சிருக்கோம்.
I feel proud myself also that I am getting the first centenary award. I'm thanking Jayashree for nice citation, kind words of introduction for me. Thanks our chief guest and my close friend Dr. Narsinger also for this function. I acknowledge presence of my teacher Dr. Ramchandran. Immediately after passing, I was there with him sometime. I was there in DRC too. And my close friend and close Dr. Anuj Meshri, who is currently President-elect. My friend Dr. Jyoti Dev, Pratap Jetwani, press people, and many more. What I am going to talk in next 25-30 minutes, the work which we have done for improving care for type 1 diabetes in India. And you know the status of type 1 diabetes in our country. So I dedicate this oration, this talk, to all those type 1 children for whom we are working. It's not me, all the diabetologists, the community, all endocrinologists, every one of us. What I am going to talk, the managing type 1 diabetes, the current status, and what is future. I don't have any financial disclosure for this presentation, except that I am involved for many of type 1 diabetes activity around the world. Person with type 1 diabetes in India, we have Life for Child, SPAD activities, CDIC, type 1 diabetes network which we have created, and Juvenile Diabetic Research Foundation, which they are supporting us. I am also the part of technical committee member of Diabetes Task Force, which is by Government of India and Department of Health as a member for making the guidelines for type 1 diabetes and also for prevention of type 2 diabetes. This is what under the Government of India. Whenever we are talking of type 1 diabetes, this slide is known to every diabetologist, everyone, every physician, that before 100 years when insulin was discovered, how it changed the life of a young boy who was otherwise before that, they all were dying without insulin. We also know the data, but I think this 2021 data which was published by International Diabetic Federation has actually changed the mind of physicians and diabetologists in our country. Before that, they were thinking that we have a major problem of type 2 diabetes, but actually it had shown that no, we are number 1 in the world with highest number of type 1 below the age of 19. Not only that, we also add every year 24,000 in this list. It means we are also highest in number of these children who are below the age of 19. Even we are not the top 10 countries in the world to have highest incidence as far as the number of type 1 diabetic we should have, but still we have a lot of type 1 in our country. So this data in 21, then 23 and 25, consistently 3 times International Diabetic Federation has shown that actually more than US we have highest number of type 1 in our country. This paper I have written long back along with Dr. Shoka Sadikot, my close friend Jyoti has written that actually, and currently I am chair of Southeast Asia, that the status of type 1 diabetes and challenges, there are many. And for Southeast Asian countries, it is common. So when I go to Bangladesh or Sri Lanka as a chair, the situation is same in all these countries. Now, who is managing type 1 diabetes? That is also very different. There is a lot of disparity. And sometimes they try to feel that, a adult endocrinologist or adult diabetologist, when he see the patient already a diabetes of 10 or 15 years of diabetes, he sees more of a complication. When a pediatric endocrinologist he has to do very intensive control of this person with diabetes, but that time child is young or the family is not accepting. Pediatrician for him is only once in a year just getting diabetic ketoacidosis, otherwise he just want to write a premixed insulin, forgetting neither patient develops hypoglycemia nor hyperglycemia. And public health expert and policy maker, for them is one of 31 notified pediatric disease, one of them is a type 1 diabetes. For that, if we talk to them, recently I was with I will show that what I was talking with government of Gujarat, when they were saying that if we dedicatedly open a type 1 clinic and from government hospital if we will be providing the insulin, suppose some child develops hypoglycemia, he may blame the government system also that why child is developing type 1 diabetes. So, for policy maker and for public health expert, again, it's a different. So that's the reason there's a lot of disparities in managing diabetes. I mean, the disparity where you are reaching out. A person may be in Chennai, he may have the best diabetologist and endocrinologist in the country, but that person is not accessible to that, or who is not interested for type 1 diabetes. He may be from a rural part of the country, but maybe going to the best person and getting the best treatment. So there is a lot of disparity in India as far as management of type 1 diabetes is concerned. What should be the goal? And goal for all these type 1 diabetes universally is the same. They have to have the best control. They should not have decay and hypoglycemia. They should have achieved the highest quality of life. And if they are in the childhood age, they should also development and psychological maturation should be there. But with the best care, they should try to get with the love and care. That the way what Vijay had just now had shown some of the children who are reaching to him and they have come. That's what the love and care they should have for the control of the diabetes. Every type 1 diabetes should have also the similarly the physiologically they should achieve and get the insulin as per their insulin as per their diet, as per their glucose should get control. Now this is not a new slide. All diabetologists know from their from their medical days, school days, that this is what a type 1 diabetes have to have an intensive control. As they have an intensive control, we'll have less and less risk of complication. But problem is, to achieve this complication, to achieve this tight control, to reduce the complication, they develop a lot of hypoglycemia. And I think in India, we read this red line more rather than this green. Most of us are more worried of hypoglycemia rather than to achieve a tight control of person with type 1 diabetes. And that's the reason we type 1 diabetes in India, 90% of them are not under good control. More than 8 A1C for type 1. Even for 2/3 of type 2 diabetes are also not under good control. But for type 1, you can say universally they are not under good control. They develop diabetic ketoacidosis. They have hypoglycemia multiple times. And we are far, far from meeting glycemic goals. Achieving glycemic goal, diabetic ketoacidosis, these all are very common. And despite multiple technology had come, but still this is the real situation, and we have the best diabetologists, best endocrinologists. Now you can't say that you don't have the ped endo, you have 500 pediatric endo, 3,000 adult endo, maybe another 2,000, 3,000, 5,000 diabetologists and many more, but still it is far from, as far as glycemic goal is concerned for type 1, it's not, we are reaching near the goal. We have to understand that a managing type 1 diabetes is not just in the clinic, not just in the hospital. They have to manage it 24/7. And this is what we talk to when policy maker or the those government officials also, that because we have to teach and educate. It's not that a person who is coming to the clinic, you have to just teach at that point of time the sugar has to be controlled. It's a 24/7 in school, in society, in everywhere. And people don't want to say that actually they are type 1 diabetes too. So this is a constant juggling. Now this I want to show you, and this is really a paper which was published in 2025 and 22 first, and this is the second edition of it, that average person in India, if he is a normal below the age of 10, today he is supposed to survive up to the age of 74. But if someone develops type 1 diabetes, this is only 19-year average life he is going to have a good quality of life. After that, either he will have with complication or he will die. So in 30s to 40s, most of type 1 who are developing their type 1 below the age of 10 years, they will die. And we are saying that we are fastest developing countries. We have third or fourth largest economy in the world, and we are having this situation that our children born in India below the age of 10, they die in their 30s and 40s. And if I compare it with the Western world, they survive. They survive like if they are a normal person survive up to the age of 75, their children will also survive up to the age of 70 or 71. Hardly there is a 4 to 6 year gap will be there. So this is the situation in our country. Why it is happening? One reason also that in early course of type 1 diabetes, actually they don't develop complication. So a pediatrician never sees in his lifetime a type 1 dying of any complication. A pediatric endo will never be an intensive diabetologist because he never sees a complication. A child who born at a 9 year with a type 1 diabetes, maybe in another 15 years is not going to have any complication, or maybe for 10 years and child will be now going to an adult endo, adult diabeto or adult physician, and they see the complications. So the first 10 to 15 years, hardly a child who is going to have the complication. Managing type 1 diabetes, nothing is changed. I'm sure that all we diabeto, endo, physicians since last 30 years after DCCT trial, this is the standard. Basal bolus, self-monitoring, diabetic education and regular follow-up. 4 things to be done. Nothing, no change, no debates. I mean, it's not like that a type 2 diabetes now should be given SGLT2 or GLP-1. But here there was no debate. For last 40 years, DCCT trial, everyone knows basal bolus, self-monitoring, regular follow-up. This is what to be done for all these patients along with lot of education. This is what we have to do. This is Dr. Oscar, he told very clearly that intensive diabetes treatment is just not more insulin. So, I mean, you just can't have a patient who is coming with a 8.5 HbA1c and here or there you are just increasing here or there by 1 or 2 units. That will not be sufficient. You have to educate. It means someone is coming with an uncontrolled diabetes does not mean increasing his insulin. It requires more education. This is one paper which is published from Germany in 2008. Why I am showing very old paper? Because now in Germany nobody will be on multiple bolus injection. All of them are on insulin pump. But what they had shown, the people who are with the more than number of bolus probably have a better control in compared to the people who are having 2 to 4 bolus injections. So this is what normally in our country, any diabeto, any endocrine who is trying to treat a type 1 diabetes would like to put the patient on 2 or 4 or 5 injections in a day. But this is the data to show that if you are doing multiple bolus, if you are checking your patient with multiple times sugar, then and then they can get a good control of diabetes. That's the only possibility. You just can't have with 1 or 2 sugar testing and with 1 or 2 times or 4 times giving them injection. That's not insufficient. So where we are going, I don't think that our patient will be ready to check their 6 or 7 or 8 times. Same thing happened when we were discussing with our health commissioner that she was telling that how it is possible for a below the age of 12 year a type 1 is getting and checking his sugar or his sugar for 5 times, 6 times, and every time they have to take the correction dose. Then I told that, madam, we should use continuous glucose monitoring. The CGM can be the right answer during this time, and this is what the continuous glucose monitoring is. The continuous glucose monitoring, sometimes when you ask your patient to do 3 or 4 times in a day, many times their sugar may be under control and we may feel that yes, sugar is well controlled, but actually speaking, there are multiple hypo and hyperglycemia, and these all you can get by continuous glucose monitoring. Unluckily, the CGM is available, but it's costly. India is not still producing in China or in Hong Kong and Taiwan, in Singapore, in these countries, more than 20-25 companies are producing continuous glucose monitoring, and I don't know why government is not still getting the CGM company to come in India and they should produce continuous glucose monitor in India, because import duty and getting it from there will be very costly. I mean, if we can produce in our own country, it should be available to us in less than $10 or maybe lesser than that. More the competition will be there, probably we will get at a less price. And why one should poke sugar multiple times? They should do continuous glucose monitoring. Do we have the data? Yes. In 1983, DCCT trial was done. After 25 years, with the older continuous glucose monitor, at that time only 3 days Medtronic continuous glucose monitor was there. In 25 years, it had shown the people who were getting hypoglycemia 62 per 100 patients here, they were getting here only 20 per 100 patients here. With the mean A1C, which was in DCCT from 9 to 7.2, here they were already well controlled with 7.6. Still they can get 7.1. So CGM have huge potential not only to reduce HbA1c but also reduce the risk of hypoglycemia for person with type 1 diabetes, and that what we can do, easily doable for our country. This is what the consensus which has been done for all type 1 all over the world. In 2017, I was part of it. Multiple consultants who are from all over the world, who are expert in technology. I was only Asian who was part of this consensus for use of continuous glucose monitoring in all type 1. All who are insulin deficient, they should be on continuous glucose monitoring. After this, there was again, when you are putting patient on continuous glucose monitoring, there is no point of checking the HbA1c. HbA1c give you the retrospective data. They give you last 3 months what was the sugar. But we want to know what is the sugar control today, and that what you can get from the time in range. And time in range is a concept in 2019 which was given again by the same group of experts. I was again part of it, and this time in range which was published, and then it is accepted all over the world. That people, if you are doing continuous glucose monitoring, no need to chase HbA1c. Try to get the time in range, and time in range more than 70% of the time you should try to get. But when we started doing, a lot of people on continuous glucose monitoring, you will find that, there is a lot of glycemic variability. Ideally, they should check their sugar multiple times and they should take multiple shots of insulin injection. But sometimes, even by putting the patients on a multiple subcutaneous insulin injection or by bolus injection, still you find that middle of the night, 2 different days may be behaving differently. And that's a real challenge for diabetologists, endocrinologists, how to explain the patient that, why my sugar on one particular day, middle of the night at 2 o'clock, it was 250, and other day it was 120. Neither you can increase the basal dose, nor you can decrease the basal dose. So that sort of a thing. And for that, you need something more. This has been published from UK. After 2017, when CGMR paper was published, in UK NHS, the government had decided to all insulin deficient patients to put on continuous glucose monitoring. It was free. So CGM was given everyone free, but still they could not achieve a tight control. It was hardly only 15-20% of the patient, but definitely risk of hypoglycemia significantly reduced, but they could not get a good control of diabetes. So they thought that it is not only the CGM which will able to control the sugar problem, particularly for patient with type 1 diabetes. Yes, we know that the same data we had shown to the government also, and they are saying, yes, this is if you are free, then why you are asking the people should be on CGM? We thought that this is the at least first step we should try to get for India. Best definitely after this insulin pump comes, that's what a continuous subcutaneous insulin infusion pump. If you give to your patient, probably they will have a better control. But unless there is a sensor augmented pump, again it will not be good. Because this is what after 2019, the American Diabetic Association had put as a it is all A evidence A that they should be on sensor augmented insulin pump. Now why I am showing you the data of 2017 and 19 and 18, because still we are far from them. In 2025, still we are talking of basal bolus, while international guideline had already produced before 5-7 years. Now nothing, there is no more a guideline which is talking of basal bolus insulin therapy to give them along with the multiple time sugar checking. At least minimum all of them should be on continuous glucose monitoring, and if you find them still there is a lot of fluctuation, they should be on insulin infusion pump. What the insulin infusion pump? Do we have the evidence? Yes. This data has been published long back. This is the published data in 2016. At that time again the older pump was there, and they had shown that these people from 7.7 they could achieve 6.9 HbA1c of 6.9, but the point was without getting hypoglycemia. So a sensor augmented pump, a patient was put, it was an older pump, not the new one which is now hybrid closed loop system. Still they could show that HbA1c is achieving less than 7 and no hypoglycemia. And this is what in 2025. Do you think that still we should go with the system? At present, if you ask me, all our type 1 diabetic patients should achieve more than 70% of the time in range. They should achieve HbA1c of less than 7, preferably less than 6.5, without getting hypoglycemia. And this should be the standard of care for our country, because even if you put any of these systems for our patient, the time in range will not be achieved by more than 70%. If you want to achieve more than 70%, it should be sensor augmented or an advanced hybrid closed loop system. That's a system which will increase and decrease your insulin level as per the sugar which is there on continuous glucose monitoring. So that's a standard of care. You check your sugar. As sugar is increasing, your insulin pump will increase your insulin. As it decreases, it will decrease. So the doctor's job will be definitely decreased in this particular condition. We had shown some of our Indian data too. The 219 patients achieving HbA1c of less than 6.8 and no hypoglycemia. This is what the Indian data which we have compiled from some of the 10 centers who are using insulin pump, and this we have published, and it has shown consistently. So it's not like the first month patient is getting control. Even after 12 months, the sugar is as control as it is. So, the patient will not have fatigue, Normally when we start something new, they may have for first 3 months and then later on, they are not having good control. This is what the different guideline which they are talking of, that how AID system should be used. And this paper which I published last year, a call to action. This I want that everyone, a standard of diabetes care should be AID system. At least you should be given a choice. I mean, to patients who had come to you, you please explain. You explain that this AID system which is available and it should be given as soon as the diagnosis is there. It should be documented if patient is not ready to take it. And the choice of device should be based on the circumstances, because in India only we have one AID system. In other parts of the world there are multiple AID systems which are there, and a national healthcare system. If at all, it can be reimbursed, like now ONGC, Indian Railway, the government, CGS supply, they started reimbursing all army and their children, they all get AID system. If you write it, you just tell them, they will get maybe in another 3 or 6 months, but it can be done. So that is what a call to action should be done. Do we have the evidence to show that the putting the patient on insulin pump will reduce the cost? Because it is very costly affair. It is almost costing 6 lakhs rupees and 20,000 rupees per month. But yes, it is cost effective for a long run. If you give a child, this is a 15-year-old boy, giving an insulin pump, and then think of his life of another 50, 60 years only on regular basis, he is using all his disposable, still it is not costly. The reason is, otherwise he is going to develop in next 10 to 15 years all those complications and may not even survive after 20 years of his type 1 diabetes. So that's the reason we had shown this, that yes, it is actually cost effective also. This is recently a paper which is published on 18 September 2025, a meta-analysis of real-world available AID system from all over the world. Dr. Mohan was one of the authors from India. The conclusion that this systemic review and meta-analysis of large-scale real-world study demonstrated that commercially available AID systems are generally associated with good glycemic outcome in routine clinical practice in people with type 1 diabetes. This is what work which we started in Gujarat. Some of the governments in India like Kerala, West Bengal, UP, even Rajasthan government had started, and we also have some work which has been done in Gujarat since last 5-7 years. We are talking constantly the model development and formatting research and mapping and landscape. This is what we propose them, a dedicated type 1 diabetes clinic. So all tertiary care hospital in India, I mean they should have, but Gujarat government had agreed for 55 centers. They are all tertiary care center where already pediatrician, physician, somewhere the honorary endocrine or a pediatric endo or diabetes is coming with 2 dietitian, 2 nurse, all of them are there, dedicated, and then we are engaging the people, digital health registry, some policy improving, and this is once in a week. So not necessarily that every day there should be a dedicated type 1 clinic. It can be done only once in a week, that is on Saturday, which we have started. This clinic we name as a Madhu Setu. In Gujarati, Madhu Setu is a diabetic bridge, I mean just to take care of all those children. This Madhu Setu clinic at medical college, and 5 medical college already we are starting. This is the clinical care, multidisciplinary team, capacity building, supplies and family and patient education with continuous glucose monitoring, which we are advocating. But at present they agreed for self-monitoring of blood glucose and glucose meter, but we are asking for CGM for everyone. This is what to be done. This working group formation with the different stakeholder, with the health commissioner, with expert group consultation and capacity building and creating a diabetic educator and the nurses, everyone are to be educated for the same capacity building workshop with care workers, which we are doing. And this is recently a newspaper which had come that we are starting along with Indian Institute of Public Health in a state for the longitudinal study. These are some of our ongoing research project which we are doing with Indian Institute of Public Health along with government of Gujarat. But what is the future? Do you think that after 100 years of insulin discovery, in another 25 or 30 years or 50 years, things will be the same? People will be still continuing to take insulin injection? No, this is what we are writing IDF 100 years. So I started with 75 years of International Diabetic Federation. This year we are celebrating 75 years of IDF. Our founder president himself was a type 1 diabetes, a first person in UK to receive insulin injection. So in 100, what we are proposing, what's the future? Maybe after 25 years, a type 1 will be cured. Maybe. And this is what our vision and this is what the research is going on. This is what the scientists are thinking of, that we have to make insulin production. We have to have the stem cell derived islet cell therapy. We have to have those new insulin production or whatever the islet cell which we are going to have, they have to be immunoprotected, because again it's an autoantibody which is actually destroying these cells, and these many clinical trials are going on. I mean, and these many molecules are there. So it's not like that, and these are the number of participants. These are phase 2 and phase 3 trials. So it's not that something which is I am talking which is not going on. This is what the future of therapy. They are already in phase 2 trial, and these are the all different monoclonal antibodies and different therapies which are there, because you have to detect type 1 diabetes not at the stage when they are at the stage 4. We have to detect them at stage 1 and 2. We have to detect them when somebody is just autoantibody positive. Unluckily, it is not possible. India is a large country, but some of the countries in the world, they already started. They started screening type 1 diabetes. Forget about once they develop diabetes, they started doing a screening program for all children, for all those who have type 1 and their family members started getting. These are some of the countries where it is already been started. And these different 7 disease modifying therapy. I had shown you some 70, but these 7 are already in phase 2 plus and stage 3. Even in phase 3 clinical trials are going on. Some of them are monoclonal antibodies, and some of them are even medicines which are also working for preventing or for curing for the type 1 diabetes. Teplizumab is already available in USA, which is a disease modifying therapy for type 1 diabetes which preserves beta cells. So there will be a time, maybe after 10 years, we may see that a diabetes can be prevented. A type 1 diabetes patient need not to have a frank diabetes, even diabetes can be prevented. At present, it is only for 2 years, but maybe after 5 or 10 years, it will be more. Can we cure? I mean, those who have developed diabetes, now forget about the disease modifying therapy, which is for prevention. But think of, can it be cured? Yes, there are these many companies who are already making islet cells. Already they are with the Vertex is a company which have produced Lentidra, and this is approved in USA. It is already beta cell replacement. This is already approved in USA. Because of the short supply, they can't give to everyone. But now they are thinking that can they make it, the Lentidra, can it be available to all US type 1 population? And this is what the phase 3 trial are going on with the Vertex. It is a cell therapy milestone, Vertex VX8880 to upgrade a pivotal trial which is going on. And these are 5 different countries. 3 of them are in US, 1 is in Europe, 1 of them in China. So these 5-6 companies are there for beta cell replacement. Now, can we improve the metabolic control? At present, there are some new generation insulin are coming, and they are already there. Once in a week, inhaled and ultra fast. Luckily in India, all 3 are available. This is something is going to change the future. Glucose responsive insulin. For a type 1, you just give 1 injection. As the glucose will increase, the insulin will get secreted. Once sugar will go down, the insulin will not be there. So this will be the future, the glucose responsive. Even adjunctive treatment had come. Now GLP-1 had shown the data. SGLT2 had shown the data. We know the AID system, but now it's a fully automated AID. It means they need not to calculate how much bolus they have to take. They have not to calculate the carbs also, and this will be future if they can't afford for beta cell replacement, or if we can't prevent the diabetes for these people. Even something orally also coming, which is not as a insulin. It is working at the different level to decrease the glucose level. But that does not mean patient need not to take the insulin for type 1 diabetes to decrease their glucose level. So the clinical care in type 1 diabetes is changing. In past, we used to give them with the therapy and insulin. That is the only therapy which was available. But today and tomorrow, probably autoimmune condition, a disease modifying therapy, immunotherapy and polypharmacology. So a type 1 diabetes, maybe after 10 years, first thing you have to check for the immunology. If they are at the risk of developing, give them immunotherapy. If they still develop type 1 diabetes, think of beta cell replacement. If they have developed still beta cell replacement is not working for them, maybe glucose responsive insulin or an advanced hybrid closed loop system will be therapy for them, not what we are treating for these type 1 diabetes. To conclude my talk, still DCCT insight remain critical in shaping type 1 diabetes care. So whenever we talk of type 1 diabetes, we have to talk for DCCT trial. That is what DCCT is primarily talking, that how type 1 diabetes to be treated. We have to create a national-wise type 1 diabetes registry, but may not be nationwide. It can be because Government of India the state is the responsible for health. So state-wise type 1 diabetes registry, rather district-wise, taluka-wise registry can be created for them, addressing gap for affordability, accessibility and awareness, expand subsidies in healthcare coverage under the government program, enhance public awareness, leveraging policy reform, scale up AID and CGM adoption, and India has potential to become a global model for managing type 1 diabetes in resource constrained setting. And we always say that we are poor country. The two things which Anuj had talked very nicely, that some of our affording class who know about type 1 diabetes, but they are not under good control. So low hanging fruit is that we should try to achieve a good control for those who are already affording. So all those who are affording class, at least we should give them best therapy. They are coming to the private setup. Those in the public setup, in the government can also afford. It's not like that the CGM and pump government can't afford. For 2,29,000, if government decide to give everyone tomorrow, it is costing less than one bullet train which we are going to propose in India. So it's not that India can't afford, it's the wish who wants to do it. To conclude my talk, this is what we have started, a dedicated type 1 meeting in India. It's a dedicated type 1 conclave. This is only inviting the people who are really interested in type 1, and we invite some of the world experts in this. This is the meeting on 6th and 7th December. I do one more meeting of Diabetes India, which is there on 12th to 15th Feb, and thanking all those international organizations who are supporting, including RSSDI Type 1 Diabetes Network, for providing free insulin and many more things to our many Indian type 1 diabetic patients. Thank you very much.
So really, first of all, at the outset, I thank the organizers and Dr. Vijay Viswanathan for giving me an opportunity to be here, where we are instituting the first Dr. Viswanathan Award. Because sometimes you start as a first, then it becomes a history. And if you are involved in a history, then you are proud of that. Very simple. So now, actually, I don't feel that I am a chief guest, because the chief guest is there in the photograph. His spirit is here. Probably with all his legacy and his institutional mechanism and his the way in which he thought for years together, hundreds or thousands of years together, and he has paved a way for many of the diabetologists in India. It is not that he treated, but he has made many doctors to treat or heal others. We used to say that in the era of digital health, in the era of artificial intelligence, in the era of machine learning, in the era of information technology, the machines or artificial intelligence can only treat or can help to treat. But the persons who had lived years before are now people like Dr. Vijay Viswanathan and others who are sitting here, the person Dr. Sabu,
all are carrying the legacy. But now we can understand that like machines, we cannot treat, we can heal. So that is why all our people are here, and it's again a privilege to be here as a guest, and I thank once again. And having an award is once again becoming a responsibility for Dr. Sabu, and many commitments he had made in the past, and from the I just searched for Dr. Sabu in the internet. Few words only can describe his lipid metabolism, metabolic disease, skills, hypertension, insulin resistance, cardiovascular system. There are innumerable terms of reference. When you go for a literature search, you will have keywords. So Dr. Sabu has many keywords which are innumerable and not countable. So I appreciate you, sir. Really, again I say that not by giving award, but by being here, it gives me immense pleasure to be a part of the history. It can never be another. I am really proud, and many people can be jealous of us. So those who are here can understand that we are in the first institution of award, and particularly in the name of Dr. Viswanathan. And if you start describing Dr. Viswanathan, and diabetologists are here, many patients are here, many beneficiaries are here, I need not tell about Dr. Viswanathan and others. Similarly, Dr. Vijay Viswanathan, my wife is a patient, but probably he will not remember, because he has saved many lives, and he will not count how many lives I have saved, how many legs I have saved. When you talk about somebody, you remember by their achievements. So if you talk about Dr. Vijay, then you have to remember your legs. That is how he is into the history. So similarly, we being a part of the government, I just want to mention what are the services we offer. And probably some of you are into the government service, or for some of you are retired from government service, or some of you are observing what is happening in the government service. Being a director of public health, I am looking after the primary health centers and national health programs. And non-communicable disease is one of the biggest national health program issue because of the epidemic transition. So earlier in the 1970s, 80s, 90s till 2000, we were more worried about communicable diseases. Now non-communicable diseases in the front as a front runner for as a disease to be tackled. We have many programs. For example, we have a hypertension screening at the household, hypertension screening at the primary health center, at the sub-center, and also in all the government institutions. Similarly, we have diabetes, and now we have started screening for the complications. Now, unless we have the help of expertise like people who are sitting here in the dais, we cannot move forward. Similarly, once you start a program, you start an intervention, you cannot stop learning with that. You have to update every day. So in that case also, we need the expertise of diabetologists. Particularly, if you read about, I was given a small book of the studies, publications released by Dr. Viswanathan. Every page, and in the year, particularly in one page, I noticed that in the year 1966, he was talking about the reversion of diabetes, remission of diabetes. In that study itself, it says that the remission has occurred from the year 18 to 66. Now I understand that it is not the diabetes that happens in the young age now. It happened in the past also. But what we lacked was diagnosis. What we lacked was acumen to understand that diabetes can happen in the young ages, and there was no program or no interventions in that period of time to screen and diagnose and bring people for preventing the complications. We do not know how many lives we have lost, how many legs we have lost, how many paralysis we have prevented. But now we can understand that with the technology, with the expertise, with updates like this, and the motivational awards like this can take us or give us more responsibility and more updates. I was talking about the program of preventing screening complications. We have a Padam Padagapam Thittam, Sirmigu Sirinir Padagapu Thittam, where we collect urine for patients who are vulnerable in the primary health centers, and just screen for albumin, we suspect and we refer to the hospitals, government hospitals, of course. Then we have a Padam Padagapam where we screen for neuropathy. Now we know that this patient or this person can have or may not have, but we refer to the hospitals. This is a system we evolve at the government side. Parallelly, the expertise is happening in the private side. If these two merge, we can have a great impact, and we look forward to have many, many associations with people like you who are sitting in the room and also sitting in the dais for having collaborations, not only for mere sake of collaboration, but for training, for making the primary health care physicians or staff nurses to suspect or screen more and more people, and also to understand the nuances of diabetes and its complications, and also refer the patients for further treatment. Now we have also Chief Minister's insurance scheme, where the patient can avail free treatment at the private hospital. So the patient will have no free of cost, no treatment cost, but mutually we can help, and we probably we can have a platform to ensure and upskill this. Similarly, we have a gestational diabetes program where we are trying to find out more and more gestational diabetes. It is said that the prevalence of gestational diabetes is around 8 to 10%, but it is very difficult for us to screen them and to find the gestational diabetes. We have a result of only 1 to 2%. But if there is a upgradation of skill, there is a more nitty-gritties which can find out the expected number of mothers with the diabetes that can help us. So all these technicalities, we want to have some expert knowledge from you, sir, all who are sitting here, and we will take that into the government side, and we can have more number of interventions instituted early and prevent complications and mortality. And once again, I thank all the organizers, particularly Dr. Vijay sir, and all who are sitting here for giving me this great opportunity. Thank you.
Rather than Diabetes Research Center, and on behalf of all of us, including those people who have come here, not only our doctors, but also the non-medical people, and even by children who have these problems of type 1 diabetes who had greeted us. So on behalf of everyone, we welcome you here, and I am really very happy that you have accepted our invitation. Dr. Somasundaram currently is a director of the Directorate of Public Health and Preventive Medicine, and he started his career in Madurai Medical College, and then later he went on to get this Master of Applied Epidemiology and a Field Epidemiology Training Program, and at the National Institute of Epidemiology Division of Indian Council of Medical Research, Chennai, Tamil Nadu. In addition, he also had gone to get this MD in Community Medicine at Madras Medical College. Then he did not stop with that. He went on to get one more diploma, postgraduate diploma in public health at Madras Medical College, Chennai. He has been having a lot of interest in various fields of the medicine. Particularly, he has uh, he has a specific experiences. In fact, he had participated in concurrent evaluation survey in the Family Health Awareness Campaign with the Chennai AIDS Control Society, and he played a key role in the social mobilization, community participation in health, family welfare, RCH, AIDS, pulse polio, IDDCP, and then the elimination of female infanticide, feticide, rehabilitation of disabled campaigns with the coordination of various organizations. And in fact, he was identified by the Department of Public Health and Preventive Medicine for coordinating the post-tsunami relief works. And in addition, he also attended various meetings in the area of reproductive and child health and acquired knowledge and skills for effective implementation of RCH and MCS services. Really, we are thrilled to see all your achievements, and congratulations for getting all these awards, and your presence in our state probably will elevate the impression about the care for all sorts of people, including the children and family wealth. So we are welcoming you, sir, on behalf of the Professor M. Viswanathan Diabetes Research Center. In addition, I think I need to welcome the orator who is going to be getting the first oration from the Professor Viswanathan Diabetes Research Center. It's the first oration which has been started by Dr. Vijay on his father's name. In fact, he had a quick discussion about a week back, told me that he is requesting Dr. Bansi Sabu to be here to receive this first oration award. I am really thrilled because Bansi Sabu had created a name in the field of diabetology, and his concentration in type 1 diabetes is something which need to be appreciated by all of you. Give him a big hand, ladies and gentlemen. And Dr. Bansi Sabu is not only a great academician, a very good organizer. In fact, if you are able to recollect the conferences what have been conducted in the past 1 decade or 2 decades, maybe 3 decades also, Bansi Sabu had been doing it in a perfect way. Meticulously, he had been arranging conferences. In fact, the people who attended Research Society of the Diabetes meeting in the beginning, way back 1996, I was a joint organizing secretary for the Congress which was happening in Savera Hotel. Subsequently, that particular meeting was attended only by about 400 people. Now the number of people who attend RSSDI is something which I cannot even imagine, innumerable numbers. I think the way in which he attracted the people, particularly our doctor colleagues, for Research Society of the Diabetes, not only to educate them, but also requesting them to implement the knowledge what is being gained out of these conferences in their clinical practice. That is much more important for us to probably recollect the activities what you have done, and you are really should be very happy to receive the first centenary oration award in the name of Professor Viswanathan. And many of you who are seated in the last row may not be knowing about Professor Viswanathan and his achievements in the past. If I am permitted to recollect with your permission, probably, I can only say that Professor Viswanathan was the great teacher. He was a professor who was holding the honorary post as a professor of medicine at Stanley Medical College. He rendered good service. Many of the people who can even recollect how he was teaching those days about medicine without any infrastructure, he was able to do it. He was the first person to start the diabetes clinic at Stanley Medical College. I think way back 1973, I remember he resigned this post from Stanley Medical College and started Vijaya Nursing Home. I remember this 1973 because I started my career in 1973 as a practitioner. So I remember that particular year when he got out of Stanley Medical College. I think I was not fortunate enough to be one of the students of Professor Viswanathan. But subsequently, I had the feeling that I had been interacting with him on many, many occasions when he was there as a managing director of Professor Viswanathan Diabetes Research Center, where he involved me as one of the important persons as a consultant to start with. And then he recognized me about my services there, and he was trying to interact with me on many, many occasions, particularly in the activities of Association of Physicians of India Chennai chapter. I think only about 4 or 5 people used to be there in Dasha Prakash Hotel, and he was a secretary. He was working under
or Rathanavelu Subramaniam, who was the president he was considered as a semi-god in those days, and that gentleman was the president, and Professor Viswanathan was the secretary, and I was the youngest person with a small mustache at that time. He entered into this. I think I had an opportunity to meet Ramchandran and Mohan also subsequently for these sort of small meetings. So this, because just Professor Viswanathan's first memorial oration, I thought I should recollect my association with Professor Viswanathan so that people on the last row or youngsters probably should know about Professor Viswanathan. And it is an occasion that probably will have to be remembered by everyone, because this is the first oration, and people who are going to get orations year after year should always remember Banshi Shabu. If you go and accept any oration, who was the first orator who had delivered the oration, you try to look at the name, and you don't even look at the other names, but look at the first name. I think, Bansi, you are lucky. Professor Viswanathan is blessing from heaven to get all these honors from Dr. Vijay Viswanathan. Vijay must be congratulated for his activities not only in his institution, but also specifically in the field of diabetic foot disease. Many diabetologists will hesitate to take up this particular field because you don't get monetary benefit, and most of them probably will be cursing you because you are not treating infections properly, you are allowing them to go for amputation. I think Dr. Vijay Viswanathan need to be appreciated because he wanted to have a prevention of diabetic foot infection, prevention of amputation. Probably he got it from his father because he was very much involved in prevention of diabetes. But Vijay Viswanathan took it as a challenge that he should prevent amputations, prevent the diabetic foot infection. So ladies and gentlemen, I don't want to take much of your time. I think I have given clarity with respect to the background of this first oration, which is going to be accepted, and we are going to honor this gentleman in the presence of our chief guest, the director. Thank you very much, ladies and gentlemen.
Honor and privilege to propose this vote of thanks on behalf of the Professor M. Viswanathan Diabetes Research Center. We extend our most sincere gratitude to all who have made this event a resounding success. We are especially grateful to our esteemed chief guest, Dr. Somasundaram sir, for gracing this occasion with his presence. Sir, your lifelong dedication and contributions to the medical field are really an inspiration to all of us. Thank you so much for coming. A special and heartfelt congratulations to Dr. Banshi Sabo. I think you will all agree that he gave a really very inspiring lecture. The distinguished recipient of the first Professor M. Viswanathan Centenary Award. Your work truly is an inspiration, sir, and we are delighted to have celebrated this milestone with you. This prestigious event would not have been possible without a guiding force. A profound thanks go to the organizing chairman, Dr. Vijay Viswanathan. As the president of the National RSSDI, your leadership and vision are indeed the cornerstone of this event's success. And also thank you to Dr. Narsingan sir for gracing this occasion. I would also like to take this opportunity for thanking the organizing team from MV Diabetes Research Center for the tireless work behind the scenes and the pharma for their support. Finally, I wish to thank all the participants here for your active participation, and your presence and engagement are what makes such events meaningful. Thank you all once again. Thank you.